Thanks everyone for coming. We have a great attendance today. See, we have 35 people approximately. So thank you for coming. I'm excited that we have two of our own here today. We're going to start with our first speaker, Jose Mazariego, and I'm quite excited to see you speak, Jose, because I can still remember you from my Biostat 2 class when you were doing your MPH here. Jose was one of those outstanding students that I asked to use his assignments as exemplars to show to other students. He was a great student, so it's very gratifying to see that he's decided to pursue his doctoral studies here in the Department of Epidemiology and Biostatistics. So I'm very pleased to introduce to you our new doctoral student, Jose, who's going to, I say a little bit more. He's currently the Haviland Fellow and works for the Center of Immigrant, Refugee, and Global Health, focusing on the use of economic methods to build policy-level data sets and link them to health studies, surveys to understand the impact of inclusive and exclusive policies on the health of immigrants. And his talk today is going to be on a systems dynamic approach to HPV vaccine uptake among adolescents in New York State. So thank you for agreeing to talk today. Actually, just one more note before we get started. Among all of the people here, I'd just like to remind you that if you or someone you know has research results that you're ready to share at a forum, please let me know. We are booked up for the rest of the spring semester, but the fall is still completely open. So please let me know. I like to book these up in advance, so I will appreciate hearing from people and from nominations as soon as possible. So with that, I'm going to hand the microphone over to Jose, and I look forward to your talk.
Thank you for having me. You can see the screen, right?
Yes.
Okay. This is a project that I've been working on for the past couple of months, and it has been a project that is still going on, and we're still working on it. So the presentation today is more of a work in progress with some preliminary results and some pre-calibration that we have done. And it is a system dynamics approach to HPV vaccine uptake among adolescents, specifically adolescent boys in New York State. I think we all know what HPV is and what the HPV vaccine does. HPV is the most commonly transmitted disease in the US. It is responsible for various types of cancers, including cervical cancer, penile cancer, throat cancer, among others. It is in the US, approximately 13 million people have become infected with HPV every year, and an additional 42 million are already infected with strains that can cause cancer. Specifically, strains 16 and 18 are known to be responsible for approximately 66% of cervical cancers in women worldwide. The HPV vaccine began in 2008, and it was recommended as a 3-dose series for females, and then the recommendations change over time, with that including boys later on, and then with new advancements in the vaccine, there's been changes in the recommendation from 3-dose to a 2-dose series, and so now adolescents can get a 2-dose series with a second dose given 6 to 12 months apart, and a 3rd dose series is recommended if the second dose is given earlier than 5 months apart. And anyone older than 15 years old is recommended to receive a 3-dose series. And so these are the updated recommendations up to June of last year, but they have changed over time since the implementation of the vaccine back in the early 2000s. So the research problem in this case is that the vaccine is recommended at a very young age before adolescents can get exposed to HPV. And this has really led to a lot of an increase in hesitancy among parents, simply because parents don't really trust the vaccine. It is not required, it is recommended. And they, over the past few years, we've seen that hesitancy increase across all vaccines. And HPV is one that, especially now, has been seen as something that is not really efficient. And the vaccine was first recommended for females, and it was later updated to include males as well. And so there's this misconception that males do not really need the vaccine, and that has really led to a very wide gap in vaccinations between females and males. So why system dynamics? Well, system dynamics emphasizes an endogenous or a feedback perspective and explains dynamics by understanding a system as a set of interacting, reinforcing and balancing feedback loops that link stocks and flows and endogenous variables. It starts by defining the problem, conceptualizing a system, formulating the model, and then eventually validating using historical data and reporting any insights. And the loops really determine the system's behavior. We have reinforcing loops, which produce some exponential growth or decline. And we have balancing loops, which produce increasing and decreasing goal-oriented behaviors. And this to the right is a very simplified version of a model that we are all very familiar with in epidemiology, which is this SIR structure. And this is a system dynamic version of it that I created for this presentation, where we have contact rate, infectivity, the total population, and I simulated 10,000 people with an infectivity of about 0.05, and we get the results that you see at the bottom. And so it is very helpful to really create dynamic and complex problems and really examine nonlinear relationships within a system. This is a causal loop diagram of the model that we created. It is a very simplified version of the causal loop diagram, but it kind of gives an idea of how the model behaves with parents intending to vaccinate their children, increasing the vaccination rate, and that increases parents with vaccinated children, when in terms increases the word of mouth, which is the impact of vaccinated parents on unvaccinated parents. And we also have providers' recommendation and parents hesitant of the HPV vaccine. The stock and flow diagram of the HPV model that we created is what really drives some of that. Is what really is the core piece of the project. And so we have adolescents, which are specifically 9 to 17 years old. And we are including 9 to 17 simply because we want to really model and simulate parents' hesitancy and parents' intention to vaccinate their children. And these are the group that is under they're under the decisions of the parents. And so this is this simulates the adolescents aging into the system and then becoming vaccinated by receiving the first dose, second dose, or third dose, and they can age out of the system at the age of 18 without receiving the vaccine or any of those dosage that are given throughout the simulation. We also have providers' recommendation, which are providers that are becoming aware of the HPV vaccine, and then they're recommending the vaccine over time. And then the other part is the parents, and these are parents who are hesitant, and then they become intending to vaccinate, and then they can vaccinate their kids, and then they get the first dose, second dose, or third dose, and then they can they can leave the system if their adolescents do not receive the first dose or the second dose after they turn 18. And the way that the parents move throughout the system is in two different ways. One, we have providers that recommend the vaccine, and that moves hesitant parents to intending. And then we have word of mouth, which are parents who have vaccinated their children, who have a very positive view of the vaccine. They can influence parents who are hesitant through word of mouth and their and kind of influencing them to get their kids vaccinated. And that influence by both the providers and other parents lead to more vaccinations across the system, which moves more parents to who have kids with the first dose, and that leads to more kids with second dose, and so on, all the way to getting a third dose. And so this is the core piece of the system as a whole. This is a very simplified version of the model. It is not the full model because it is very complex and it is very busy, but this is a simplified version of it. And this is still a work in progress, and so we have really we're still working on it, and we're getting some new data, but we had some preliminary results that were simulated before I started changing the structure of the model. And this is what we see here. And these are some simulations that were done on the number of boys that have the first dose, the number of boys that have the second dose, and the number of boys that have the third dose. And you can see that it fits the data points very, very well. There's still some inconsistency, but we can see that the historical data and the simulated data do follow a very similar path in all of the three doses, all the way from 2008 to 2015. And these data points were taken from the NIST data set from the CDC. So these are very public available data. And so that has been one of the limitations in the simulation of this model. 3 scenarios were tested after the calibration of the first model, which was increasing provider recommendation to 100%, increasing adherence of parents to 90%, and a 50% increase in word of mouth by parents. And you can see that provider recommendation and adherence of parents had the biggest impact in increasing vaccine uptake. Word of mouth did not really have any a big impact in uptake, and this is and this was a very interesting result to see. But these 3 scenarios were simulated just to try to understand the different strategies that we can implement to really increase uptake of the HPV vaccine. So we saw, like I mentioned, word of mouth did not really have a big effect on vaccine uptake. And this might be because in this model, we are simulating positive word of mouth, which may not really have a big effect on vaccine uptake. For example, parents who are hesitant may not really become intended simply by other parents. Telling them to, negative word of mouth may have a bigger impact compared to positive one. We did see that provider recommendation and parental adherence had the biggest effect in vaccine uptake, and this is reasonable given that providers and parents parents probably have more trust in providers, and that can lead to more vaccine uptake. And parents who had kids with the first dose are more likely to continue on to get the second and third dose, which was seen in this simulation. Given the current administration views on vaccination, I think it's very important to implement some of these policies that I showed here, that is very important for providers to continue recommending that vaccine and discussing the benefits with parents. A major limitation of this method is that it assumes homogeneous groups at each level. So each stock is a group of people, and this method assumes a very homogeneous group that are not very different from one another. And this is very one of the major limitations because vaccine uptake may differ across other groups like race and ethnicity, for example, as well as insurance type. And one of the next steps that we have is to finalize the structure of the model and calibrate the model using data from the New York State immunization registry, hopefully get some data from the citywide immunization registry, which is it's a separate one from the state because the state doesn't provide New York City data. And so we have to go to both the New York State Department of Health and the New York City registry, as well as the NIS team, which is a public data from the CDC that provides data on hesitancy, provide recommendation, and intention to vaccinate their kids. And just some acknowledgements to a group of people who have been very supportive throughout this project and who have really helped me get data and really continue on with this project.
Thanks, Jose. And we can take a little bit of time to take questions right away. And you can either type a question into the chat or put your hand up and ask, as I see Rebecca Zimba has. Rebecca, do you want to?
Sure. Hi. As a parent of teenagers who have received the HPV vaccine before they were 14 years old, so I'm in that other group, it wouldn't occur to me to talk about this with other parents. So I kind of wanted to get more of a sense of the motivation for that, like, especially since you could talk about like, oh, my kids didn't have a reaction to it, but the effect of vaccination is decades in the future in terms of preventing cancer. So I wanted to hear you dig into that a little more. Yeah.
Yeah, that has been a conversation that we've had multiple times with other individuals, and it is, you know, and that might be one of the reasons why in the simulation we don't really see that big of an effect, because you don't really see the benefit of the vaccine probably years later, and probably you don't even see the benefit because there's you know, many parents may not think of it as a benefit if the disease is not really happening, right? So
well, and not even that, like, again, I wouldn't talk about this with other parents. It wouldn't occur to me to be like, oh, have your kids gotten the HPV vaccine? Like any vaccine, really. Maybe that would be different if I had younger kids and I was living in West Texas. But
yeah, I think it's more of a kind of a, you know, group of, yeah, parents may not go out and discuss the vaccine with other parents, but they might discuss it within their group of friends or family members who might, you know, they might say, I got my kid vaccinated, and then they might raise that discussion, especially now with the vaccine hesitancy really increasing. So that might, you know, that influence might be greater now than it was at the beginning of the introduction of the vaccine.
Fair point. Very, very cool work. Thanks for presenting that.
I have a very basic question. How can the data that you're looking for from these registries provide support or refute a hypothesis with this model?
Yes, the data helps in the calibration of the model. So we have different parameters in the model, and then having data of the number of kids that have been vaccinated, we're able to adjust the parameters to get that simulation as close as possible to the actual historical data. And that kind of assures us that those parameter numbers are in a way reasonable. And then we can simulate by changing those parameters and see how
parameters being
change.
Like the probability of getting your second vaccine conditional on having got the first vaccine?
Not necessarily. For example, in this model, one of the parameters is the effect of word of mouth and the effect of provider recommendation, and that may change parents from one stock to the next, which influences vaccination of adolescents.
I just at a basic level, I don't understand how that information could be inferred from the data in immunization records, just at like a basic level.
I think it's difficult to kind of discuss it in probabilistic terms, because it is more of we use the data as a way to validate the model, to validate the simulation of the model, and that parameter and those parameters that we set drive that simulation. And so we use those parameters, we adjust those parameters to get, in a way, very close to the historical data, to get kind of a validity point of to get some validation that the system that we have created is in a way able to capture historical data correctly.
So in the end, can you get a p-value?
Not necessarily. We can use like Markov chain Monte Carlo simulation to estimate credible intervals to see where the parameter might fall, but not necessarily p-values.
And I think maybe, Levi, what you're sort of not saying is, would we interpret any of those parameters causally? I mean, there's so much that you're assuming when you're making these models, even if it does end up fitting the historical data. Like, can we really say that this caused that in a causal inference kind of way using system dynamics modeling?
I think it depends. I think we can kind of have an argument that, yeah, there is some causal effect going on, not necessarily that it is a cause, but that there is an effect that is driven by those factors.
It seems good for hypothesis generation.
Yeah, it seems maybe like the hypothesis that I mean, I guess in theory, I mean, a credible interval does test a hypothesis, but it has no overlap with the hypotheses that you would test with an epidemiological model, with a logistic regression, with, I don't know, multi-state model or something from traditional epidemiology. It's a completely separate set of hypotheses, it seems to me. Does that sound fair?
Yeah, sorry, can you put the point and kind of?
Well, I'm trying to say like where is there overlap or not overlap in what we would do with EPI2 methods? And it sounds to me like there's almost no overlap in the hypotheses that you would test.
Yeah, I mean, there's some papers that have been written about, system dynamic modeling and causal inferencing in epidemiology, and how we can integrate those two, or EPI can take some ideas from system dynamic modeling. It is in a way similar, because the causal loop diagram kind of resembles a DAG in a way, just that the difference is that we don't really have a time component in a causal loop diagram like we do in a DAG, right, where time is flowing from left to right. So there are some similarities. I think the approach is different. I think it's more of this system dynamics is, even though it's a field, there is more about a method to really try to understand a lot of complex behaviors that may be difficult to capture in epidemiology.
All right. Chloe Mirzai made the comment that effect driven by some factor is the definition of a cause. All right. So we can continue the discussion afterwards. Thank you, Jose. I think it's time to switch over to our other presentation. So thank you very much. And I'm going to now introduce our next speaker, who is new at the school in a different way. Professor Constantin Yiannoutsos is new faculty at the School of Public Health. He started just in the fall and came as a full professor from Indiana University. So we're excited to have him, and this will be his first talk at the school since joining our faculty. This semester, Constantin is teaching Biostatistics 1 and introducing some simulation methods and interesting new methods to that course. So I'm pleased to introduce Professor Yiannoutsos and his talk today, Cross-sectional Estimates in Multi-State Models and Applications in the HIV Cascade of Care. So thank you for agreeing to come and talk. I'm sorry that we're having to do this. We're sitting in our separate offices 3 doors apart right now. But so it is for today. Maybe next time we'll have a room.
Yeah, thank you. And everyone can hear me?
Yeah.
Excellent. So, and you can see my screen this time. Okay, yeah. 2 for 2. Okay, so thank you very much, Levi, for inviting me. I'm very excited to have joined CUNY SPH and the Department of Epi and Biostat. I'm a biostatistician, and in addition to that, I co-direct a large observational cohort, and by observational we mean not non-randomized type of situation, a routine clinical care cohort of people living with HIV in East Africa, and we are following now for over 2 decades about 500,000 patients who receive care and treatment in this context. And my talk emanates from data obtained from clinical care from some of these individuals, and instills some statistical methodology to try to make sense of and gain some insight in the type of care, also in the success of ultimately of the provision of this care. The basic issue here is the use of what we call multi-state models, which is a statistical technology to give us some insight on the what we call the access that patients have of these care and treatment programs. So without further ado, let's get started. And with just a brief description of what we call the HIV cascade of care. And this is a generalizable concept to other diseases as well. And our motivating study involves, which was published about a year ago in the Journal of AIDS by my colleagues Bakoyannis, Yorgos Bakoyannis at Indiana University, and Batya Elul, among others, in Columbia, at Columbia. And this study involves 35,000+ persons aged 15 years and older, and these individuals are living with HIV and obtain care between the years of 2014 and 2020 in about 78 clinics in our purview. The one thing that you must keep in mind is that these individuals have been culled from a broader cohort, and the added requirement has been that they had at least one viral load measurement. And this is important because, as we will see, viral suppression will be at the core of our analysis here, and we can discuss later on about how representative this cohort or subcohort is to the broader cohort, and whether we think that having a viral load measurement might be associated with some of the other issues or risk factors in this cohort. In any case, this is what we have here, and this is what we're gonna, so it's like the song, this is my story and I'm sticking to it. So what is the HIV cascade of care. So the way that we can abstract this and create a kind of a model of this of the process of an individual through this cascade, and why we call it in fact a cascade, is that we are visualizing a number of what we call states, right? So those states, and I use this word because the technology, the statistical methodology that is going to be applied is going to be that of multi-state models. So these multiple states involve a state, for example, that an individual enters care, accesses care. So that's the first state. And we separate that from the state where the person is actually put on antiretroviral, as we call it, or anti-HIV therapy. The second stage is when the person is actually accessing ART or antiretroviral therapy, but we exclude from that state the situation where the person has suppressed virus. The third state is actually a person, and in most cases, or in virtually all cases, this is a person who is in fact receiving treatment and becomes virally suppressed. That means there is a viral load measurement for HIV viral load, and it comes back as the virus being undetectable or below a certain threshold. A fourth stage is what we call being in a gap in care. That means having disengaged either temporarily or permanently from care. And the fifth and final state is that the person is deceased. There's an extra state that we're adding for technical reasons, and that is that the person is censored, and that by that we mean that the person is no longer generating or coming in for visits, but it's not the period between the time that this happens and the time that we close the database is not long enough, so that person is not really in a gap in care. It's just that we stopped the study, so they are censored. One of the things that we're trying to do with these data is to make some programmatic statements and what we call a program monitoring evaluation, or M&E in the epi parlance of the program. And ultimately, what we want to do is go to a situation where we can start evaluating various guidelines. The major one, of course, is the United Nations Joint Program in HIV/AIDS, or UNAIDS, and the guideline is called 90-90-90, which means that 90% of those who are HIV positive know about their disease status, 90% of those are accessing care, and 90% of those, the third 90, is the ones that are maintaining care and are virally suppressed. So now they're going to 95, 95, 95. But in any case, the point is that this is a big part of our evaluation, our understanding of whether we are succeeding in satisfying these guidelines. So moving right along, and please interrupt me if there are any questions, or you can wait for at the end. We, as Jose earlier, we are putting up there a conceptual framework, and that conceptual framework has these 5 states, and then we posit a structure on it which considers various transitions. The nice thing about these models is that you can actually have what is called a patient churn through the cascade. That means you don't have a situation where a patient goes in one direction and gets lost, but it can come back to another state, then go to the same or a different state, and so on. One state that is, of course, special is the death state, and this is what we call an absorbing state, because once you go in that state, you're not coming out. So there are no, it's like the Aesop's myth, where all these animals would go into the lair of the lion, and there were no tracks coming out. So that's like sort of like an absorbing state. The other states potentially have transitions that are bidirectional. Now, there are some transitions here that I'm considering a little iffy. For example, you may argue whether there should be transitions to the viral suppression states that do not go through ART. That's beside the point, though. The whole point what I'm trying to show you is that this is our understanding, or general understanding of what this model that we're ultimately going to be putting together it looks like. Okay, so what is multi-state models? And here I need to, before I go into this, there will be some technical language, and I will try to make it accessible to everyone. I've tried very hard to limit some of the mathematics. So if there is a mathematical formula, I will use it more for as a reason, as an anchor for discussion, rather than actually going through it and explaining it in the mathematical detail as I would if I had a much more technical audience. So anyway, so what are these MSMs? And these MSMs is basically like the HIV cascade of care, is that you have these people and they're moving through, and you have this, what we call in mathematics, this stochastic or random process, which is a process in time, which we call XT. And during that, using this process, patients move through time and they visit these states, and that's all that means. And the state space is, in our case, a group of 5 states, and a subgroup of that could be what we call an absorbing state. In this case, the only absorbing state, of course, is the death state. So, but that's basically what the patients do. The time passes, and as they pass, they walk from one state to the other, sort of like Monopoly or something. So that's basically the simplified version of what a multi-state model is. And the question here is, how do we use it? How do we, what kind of methods do we use to obtain estimates from that model? And how we can actually, and this is actually the gist of the talk, do we turn these estimates into something that can then be actionable, it can turn into actionable policy? So here is another set of mathematical things. Don't get too alarmed over them, but basically one of the ways that we do estimation is by estimating these transition probabilities. And this is exactly what that means. It's basically the probability that at any point in time, you will transition from one state, let's call it S, to another state, let's call it I, to another state, let's call it J. And you're at state I at a certain time point, here I call it S, and then you go to state J at another time point with some probability, and that probability gets modified based on a number of factors, and some of these factors that your previous state that you're coming from, and other factors are all the other states that you have visited. And you can understand how this can immediately become extremely, extremely complicated, because people can have very intricate and if you want to be realistic anyway, patterns of visiting various states. They come here, they go there, they go to another state, they come back, etc. They turn around, back and forth, and so on. This, among those things, that little calligraphic F is what makes things very difficult, because that F essentially is the history of all the transitions that you made before you ended up in the previous state from which now you're going to go to this new state. So that's basically what we're looking at here. And so that's the transition probability. And thankfully, things are not very desperate because there is the so-called Markov property. And the Markov property says basically that, don't worry about that calligraphic F thingy at all. All you need to know is the state you're coming from, and in order to estimate the probability in terms of the state you're going to. So you say, oh, if that's the case, then things are much easier. So we can use that. So what kind of technology do we use? Well, we use, and don't worry about this stuff here. Basically, what you use, you're basically saying you're going from, once you get to one state, then you start the clock, almost like a survival, not almost, exactly like a survival analysis, conditional though that you're on this state at this time. And then you're going to have this competing risk type of situation where you're going to go to any of the other states, right? So the clock is ticking. So that's some of the stuff. And this thing here is like a type of a hazard, if you're familiar with survival analysis. And this is like a cumulative hazard. And and this is basically the stuff we're using. So I'm not going to stay here because I don't want to make this talk very technical. And you're using what is called the Allen-Johansson estimator to estimate these entire matrix of decisions and transitions from one state to the other, with having all the probabilities of getting there and coming back, except in the case, of course, of the absorbing states where you cannot come back. So, okay, well, that's all great, and there is the technology to do that. The problem, though, that we have in our setting is that the Markov property is not correct. You know, that kind of puts the kibosh on any situation where you can actually use the Markov property. So now what, right? Because without it, it's very hard to do the estimation. So the point is, are we stuck here? What can we do? Well, no, we're not. And the reason we're not stuck is because actually, who cares about transitions at the end of the day, right? These are not concepts that are accessible to everyday person, even me. I mean, I'm doing this for a while. So a better, and I think a more clinically and from a health policy perspective, endpoint is the so-called state occupation probability. And what does that mean? Basically, it means what is the probability that at any point in time you are at state, say, J, marginally. We don't care given that you came from this state or that state. So basically, this probability accumulates all the probabilities of coming from state 1 to state 2, from state 3 to state 2, from state 4, whatever, to this state, and puts them all together into a cumulative probability of being at this point in time at this state. And that's the state occupation probability. And that's a great thing because, as it has been shown, the state occupation probability can be estimated even if you assume wrongly that the underlying structure is Markovian. So what does that mean? It means that I can use the Markovian simplification of the model to do estimation, and then the stuff I get out, okay, it's not going to be correct on the transition part, but it's going to be ultimately correct on the aggregation of all these probabilities into a single state probability. So that's at least the way I understand what it means to that I can consistently estimate this, even if I'm wrong about the whether the underlying structure is Markovian or not, right? So I can use, in that case, the Markovian structure to do the estimation, and I come up with reasonable estimates. And in fact, I argue this is really what I should be looking for, because I want to know where my patients are at any point in time, right? It's like it's 10 o'clock, do you know where your kids are, basically, right? Same thing. So let me go over the study that we published here. So hopefully these things will start making sense. So first of all, let's talk practice, right? How practically do we do this? What do the data look like? So the data look like this. Here is a patient, and there are multiple lines per patient. So, so at time S0, this patient was in state 1. That means they enter care, and usually that happens in the first line. And then about at time 0.05, which is day 20, the scale here is in terms of 1 year, or 365.25 days. So at time 20 days, they entered state 2, where they were put on ART. Then from state 2, at time 0.36, which is about day 130, they achieved viral suppression. So they had a viral load within about 4 months of getting on ART, and they showed that they had suppressed virus. Then what happened to this person? They stayed for another 1.5 years or so in care, and then they were censored. So there's your one person data, and then you go to the next and the next, over 35,000 of those. Okay. And here are the state occupation probabilities. So basically you have the yellow is being in care, the green is being on ART, The teal is being virally suppressed, gap in care is the blue, and the dark blue is deaths. And let me make some remarks for this. It shows that, first of all, from a technical perspective, these are not Kaplan-Meiers, okay? So even though they kind of look in the beginning like that, they're not. And the big difference between state occupation probabilities and Kaplan-Meier survival is that these are not monotonic functions. So they can go down, but they can also go up, right? As we see with, for example, the probability of viral suppression. The other thing is, a nice thing to see is how quickly people are put in on HIV care. And, you know, for people that have been in the business for a long time, we used to have triaged care, and people would take months to get in care. After 2015, which was one of the reasons that we cut off the data at 2014, there was this guideline about what's called test and treat. So you test positive, immediately you were put into care. You can see that that by 1 year, there's pretty much 2% of the population that is not in care, and which is kind of an aberration because virtually everyone should be in care by that point. So this is a nice evidence-based way to see the success, in fact, in real time of this policy. We also see that ART, people remain on ART for very little time before they migrate into the viral suppression state. But here, the news are not as great because you have a steady state of about 10 to 15% of people who just do not achieve viral suppression. And that may have to do with churning back and forth from the gap in care state. So they stop there, they disengage from care, they go whatever, then they come back, they're not suppressed. So now they migrate to the ART non-suppressed state and so on. However, you do see that the suppressed rate keeps going up. And my idea is that the longer people remain in care, or at least there is some frailty issue here. So the people who remain in care are the ones that can be adherent to care, or they migrate to the death state. So the people that do remain in care for a longer period of time are the people who are ultimately going to be successful. So that's what you can get out of this figure. You can also disaggregate the data, so you can start seeing how these probabilities, the state occupation probabilities, are able to show you different ways that people are based on various, in this case, baseline characteristics. So for example, here we have one of those states, which is the viral suppression. And we see that, for example, men and women have basically, I don't care about the p-value so too much, they have pretty much the same level of viral suppression. They're all in the low 80s, mid 80s, low 90s by the 5th year. We do see, and I'm going to make this a little bigger, we do see a larger difference here in this case, and we see here that this is by age, and you can see that in terms of viral suppression, the very young adolescents and people under or up to 25 years of age seem to have a significantly lower significantly lower rates of viral suppression, and that pretty much extends all the way out to 5th or 6th year. It turns out they have very higher rates of gaps in care as well, which surprises no one. But this is something that you can see that this is a really, really special population, and in fact is the hardcore of our failure. This population and a couple of other populations, like pregnant women, for example, are at the heart of our inability to get to that, to make that final step of actually having a control. And of course, some of the situation now with 4 and 8, but that's a political issue, not a statistical one. But here, definitely, we see how that population is a special population. In terms of the starting CD4 count, not a great deal of differentiation here. It appears that people at the highest, the higher CD4 counts have, and this has been published earlier seem to have the best results. It appears that people who came into care after 2015 seem to be faring better, and that I do not know whether it's related to the newer drugs or the fact that they were initiated in care earlier, and thus have lower gaps in care or lower attrition or death or whatever. But it does appear that there's a huge difference between people who entered care prior to 2015 and those who entered care after 2015, and that's something, of course, of ongoing investigation. So that's the remarks. Now, the main part of the talk, though, and you saw from the title, is how do we turn these statements into cross-sectional statements? So you may be aware of what these studies that were done by the FIA, these public health evaluation studies that were done, and these were national surveys, extremely complex, took years to do, a lot of money. But they were able to look at a specific point in time and tell you, we have this many people right there today on the 5th of March 2025 who are virally suppressed. We have this many who are in care. We have this many who are not in care. We have this many who died recently and all that. You know, can we actually use the data that I just showed to you to create similar estimates? Because if we could, then it wouldn't be as, obviously there's no free lunch. It's not going to be as effective or as rigorous as doing a national survey, but you can do this with clinical data pretty much daily. So you can certainly fill in those gaps between successive, if nothing else, successive surveys, and understand and have a little bit of your finger on the pulse. The question, though, is how do you turn in this inherently prospective estimate of the state occupation probabilities into something that's retrospective? And what do I mean by retrospective? So let's see. So this is the situation. And remember, if you're doing your basic Kaplan-Meier or survival analysis, or even competing risk thing, you take all these people that are coming in to care and you line these ones, the entry, for time 0, and you go forward. So the staggered piece is going to be on the right when you're looking forward. Here, I want to say, okay, I'm sitting here on March 5th of 2025, and I'm looking back, and I want to know how many of these people are virally suppressed. So I can say, okay, here's one, that guy's not. Oh no, sorry, here's one, here's another one. This guy's dead and this guy's dead. So either they're virally suppressed 2 out of 4. If you want to exclude anyone who's dead and is not present here, it's 2 out of 3. That's it, right? But I have to go backwards and see where is this point of today with respect to when this person, this person, this person, this person have entered. So basically you're turning your point of view and looking backwards. So you have to develop a slightly different set of methods to turn the state occupation probabilities, which is a forward-looking thing, to something that you can specify calendar data and look back and pull all these state occupation probabilities based on how far in each of these persons' time your today time is, right? So that's basically what we are going to do. I hope this is clear. Given that, though, and that's the cool thing about this, if you can do that, then we can actually use our routinely obtained clinical data to actually estimate the last 290s. I can estimate how many people are in care, and I certainly can estimate of those how many people are of those who entered into care, how many are on ART, and of those, how many are virally suppressed. So I can estimate the last 290s, with the caveat that I cannot estimate the first 90, which is how many people who are HIV positive know about their disease, because by definition, in order to for me to access their data, they have to be part of my cohort, and for them to be part of their cohort, they have to be diagnosed HIV positive, so I don't know what the denominator is in the community. The conditional probability that they are HIV positive and they are in my cohort is 100%. So, but I can actually say something about the second and the third 90. And the way I'm going to do that is basically I'm going to sum up and take the average of these 4 people in this case, or the average of 35,000 people. And basically I'm going to say, okay, what is the probability out of 35,000 people that, in this case, on May 30th, 2020, how many of those are on ART? How many of those are virally suppressed, right? And the way I do that, and forgive the math, is I basically take the state occupation probabilities and I average them out, just as of today. And today has to be translated into a state occupation probability, because looking back to see how far is today, that capital T, I, how far is this today from the start of this person? Okay, so let's say it's 5 years. Okay, at 5 years, the state occupation probability for this person to be virally suppressed is this much. So I take that. Oh, how far is from this other person's 2.5 years? What is the state occupation probability that at 2.5 years they are virally suppressed? Is that? Give me that. So that way, and then I take the average all those probabilities as of whatever my calendar time is, and I put in a hopper, and out come these estimates, right? And based on our study, the estimate is that 90% of those who were were in care as of May 30th, 2020, were on ART, and 81% were virally suppressed, or almost 91% of those who were on ART, because that 81% is unconditional whether they were or they were not on ART. But it looks like, at least in my study, that both the second and the third 90 are alive and well. Not 95, okay, but 90, that's fine. So that was done with this prospective to retrospective type of, which actually I have to give kudos to my collaborator and colleague and friend Batya Lu for coming up and asking that question and motivating us to go and create some mathematical techniques to be able to do this. And then Yorgos Bakoyannis was the one who actually came up with the math and actually proved that this estimator is what we call strongly consistent, which means it's estimating the right thing. So to close out this presentation as a form of discussions is what are the insights that we get from the prospective stuff. So okay, at 1 year we have about 2.8 patients are in care but not on ART. The vast majority, almost 90% at 1 year were on ART, but only about 60% were virally suppressed. This strikes me as a bit low. I wonder whether this has to do with data availability in terms of having their first viral load by 1 year or not. So the one that's definitely low is this guy, that only 0.3% were deceased, and this is an ongoing and perennial problem in our observational studies, because we don't have great death capture. So a lot of these guys who are in gaps in care are actually deceased. We also have 5 years out, which is actually the strength of the study, and it shows that after the first year, basically, with the exception of viral suppression, there's very little changes that happen. So, which supports some of our earlier findings and publications that really early in intervention in terms of adherence and keeping people in care, that's where the game is played, is early on. And of course, the unsurprising result that young people have worse outcomes. In terms of the 90-90-90, which is the retrospective question, the mid-2020 snapshot shows that at least the 90-90 is alive and well in our study, and it actually is lower than some of the estimates that we're seeing with the FIA in our region, which is Kenya, Uganda, and Tanzania. I don't know why that is. The FIA actually found better results than we did. At the same time, the FIA study based its estimates on very few patients in our group, which is one of the weaknesses, and not in our group, in our region, which is one of the weaknesses of these national surveys, which might be nationally representative, but are not great when we're talking subnational estimates. So for example, in the Kenya FIA, there were only 24 individuals in our largest county, where we have most of our patients coming from, whereas in our study there were almost 8,000 patients. So who knows whether some of the discrepancies, for example, in the Kenya data between our study and the FIA study are based on just basic sample size differences. And that's all I have to say today. I stole this from UNAIDS, and wanted to thank my colleagues, Yorgos Bagogiannis, Beverly Music, Steve Brown, our data managers, without whom we wouldn't have air to breathe. My MPI, Augur Samir and and Will Skalustian, and our site investigators, Barbara Calsanova, Lamek Gertrude Nagikosi, Rita and Rita Liamuya. One thing I wanted to show you is here's a CDC link. So let's see. Well, that link doesn't work anymore. So draw any conclusion as you wish from that statement. Thank you.
Thank you, Constantin. I'm going to start off. I'll keep an eye out for more questions too. But the thing that really struck me was how similar, in some ways, what you were writing down looked like to what I understand of the system dynamics modeling. I mean, are they not both? You're talking about, you wrote a differential equation with a multi-state model. The main difference I could see, tell me if I'm wrong, was that with you, time zero is the same for each, is different for each patient. Time zero is defined by entry into care, whereas for Jose, time zero is 1995 or whatever. And so the state is like at an individual level or at this whole population level.
I mean, I'm not familiar with dynamic modeling, but in Jose's study, it might be a situation where everyone was available at 1995. In my study, they come in when they come in, and then you kind of line them all up at time zero by moving them left. But I can understand where you're thinking about the differential equation will come, and ultimately we're not far there because we are ultimately, that limit there of the transition intensity is essentially a derivative. So it's basically a rate of instantaneous jump from one state to the other. Now that has something to do with survival analysis and competing risk, because both survival analysis is a single state situation and competing risk is one to multiple states. So the technology does include survival analysis and competing risk as special cases. So we're not, going completely off the deep end here with in terms of the novelty of the methods. The slightly novel thing is to show that you can actually line people up on the right and be able to make statements based on specific times, calendar times.
Left censoring, was it?
Even with censoring, basically, yeah, if somebody has been censored before now, either because they died or they censored, they transferred, the probability, of course, that they will be virally suppressed will be affected as well.
Speaking of that, does the kind of under capturing of death make you worried that the censored people are disproportionately not in care or sicker?
So their censoring is the gap in care. So the censored people, in order to be censored but not to be in a gap, so I should have said that, I know Bev Music is on, who actually did the data with Steve Brown, did the two data managers who did the data, but I think the definition was that you are without a visit for at least 60 or 90 days, something like that. So if your last visit was within like 30 or 59 days from database closure, you would be censored, but not in a gap in care. Now that gives you plenty of time to die in that 59-day period. So we could have some people who are censored actually being dead or being in a gap in care. Or the people, I'm more concerned for people who are in a gap in care for a long period of time. What is happening to these people? And obviously that's a mixture of, and this is a part of our ongoing research efforts, it's a mixture of people who have transferred, but we don't know about it. It's called silent transfers, but there's also a significant proportion of them are dead. And actually, I have a footnote there that another study in Zambia with a former colleague of ours, Alvin Gang, actually went and outreached a portion of the people who were lost and was able to adjust their estimates of death, and they found that in 1 year death was 6.9%. I think that's a bit high for recent antiretroviral programs, but it certainly shows that 0.3% is bogus. I mean, I agree with that.
So everyone who's censored was assumed to be either in a gap in care or dead. So the 90%,
or they could be in care as well. I mean, they don't come in every day. So let's say that their last visit was 20 days before the database closure. The next visit is in 10 days after database closure. They could very well come to that visit and continue to be in care. So censoring is censoring.
Database closure being like an administrative end of follow-up as opposed to
loss. So basically when we say, okay, we're gonna freeze the database as of today so we can create this analysis database so we can give it to Constantin and Yiannoutsos and those guys and they can do the analysis.
But like people who are censored because they were lost to follow-up, they're all assumed to be.
No, they are in a gap in care state. No, censoring because of loss to follow-up is gap in care.
That's just gap in care. Okay, got it.
And you can actually come back from gap in care. Gotcha. Mind you. So you can go and not come for a visit for 6 months, say, and then come back. And then you were gap in care for a period of that. That's why we call it a gap in care versus loss to follow-up. Loss to follow-up is more like an absorbing state. When you're lost to follow-up, we're not going to see you again.
Makes sense.
Now, trying to incorporate potentially outreach of a subset of a population in a realistic joint model or rather multi-state model, now that's hard.
I have another. Oh, sorry. Go ahead.
No. It's hard. So let me stop there. Yeah, go ahead.
I have another kind of dumb question. When you just care about the marginal frequencies at a given time, why not just look at that directly instead of estimating it via the state space model with the Markov assumption? Even though apparently it seems like they would both give you the same answer, but the former might be simpler. Or?
I mean, I don't know about that. I mean, because there's a lot of information going into estimating these transition probabilities. So by you saying, okay, here are the 35,000 people that I've been following, You know, go out there in the records room and find out how many of those have viral suppression. Also, the other thing is they're not all going to have viral load today. You know, so you have to take into account the fact that viral load examinations and measurements vary over time. They might have, it's a kind of a staggered type of every 6 months, every year, etc.
So you need the model basically to assign people to states in between when they're actually measured.
Right. Right. So it's a bit more complicated because, and there are many technical issues that need to be ironed out. For example, because we were saying that a person with a viral test or a viral measurement is considered virally suppressed until another viral test shows that they're not. So how long are we going to pull that forward? You know, so what we decided to do, for example, there are some things that I completely glossed over, is that after I think either a year or so without a viral load test, we censored individuals so that we wouldn't have to make those calls and say, so this guy had a viral load in 2015 and, you know, it's 2025, we can still consider them suppressed 10 years later just because they had that suppressed viral load a decade ago.
Can I ask a question about that? Do you have evidence that, for example, I don't know if you know in that particular case, but if you had evidence that they were still in care, would you still censor them?
Oh no, they weren't still in care. Absolutely, I would still censor them.
Okay. Wasn't there a state for people who had a gap in care?
Yes, but you can still be in care. You're just not generating, for some reason or another, either nobody assigned you a viral load. I mean, we're talking a resource limited setting here.
Absolutely.
Or you know, USAID disbanded, and we're not doing labs anymore, which is actually happening right now, or whatever. Or there's a tribal conflict or something, and you're not getting the viral load that you were supposed to be getting. So I can't carry you for a decade based on the viral load, you know, 10 years ago. Even though you're still coming dutifully to your visits, yeah.
So then 90% is conservative then, right? Would you say?
Well, I don't know. The FIA study says 96. I think 96 is way up, 96%. There's no way that there's 96% given what we know about people's adherence patterns and things like that. So who knows? I think 91, I can believe. It might be a little, I don't know. I don't think it's conservative personally. I think it's just right. But that's you know, we're entering a data-free zone there.
How could it be anti-conservative? Is that even possible? Oh, is my mic working?
No, we can hear you.
Yeah.
I mean, if people who have viral loads are more likely to be not suppressed, you might get a little inflation of the unsuppressed. There might be some clinical preference given to people who seem to be not to be doing great, or to people early on. And in fact, some of those algorithms is to get a viral load pretty quickly after you start therapy. And if it's suppressed, then you just allow the person to go at least a year without a viral load. If they're unsuppressed, then there is a viral load within several months of that first viral load. So there's definitely correlation there. There's no way you can avoid that. So you may have a situation where people that are more sparsely tested might be better off. So who knows?
I have a question.
Oh yeah.
I was just wondering about this because the people who are not on ART are going to be more likely to die. So I was thinking, if you run this model for many more and more years, won't it be that you'll get more and more people? You'll only get the people who were that were sort of that are on ART, so that 20 years out, 99% would be on ART because the other ones are dead. So the estimate you get depends on how long you've been running the model for.
And that's what I mentioned about the frailty, that there is a tendency of people who are doing better to stay on. So I think you're absolutely correct. My late results, I mean, anything after 5 or 6 years, I would, in this population, I would start worrying about. And in fact, if you see back here, after, I'm still sharing. Okay, so it's this precipitous increase of the viral suppression comes after 4 years or so. So that's probably what's happening there. I think what's happening is that all the people who are, a lot of the people who are not doing well are just, they're leaving us one way or another.
Thank you.
You're welcome.
But if they're leaving, sorry, why wouldn't they just be in gap in care? Or, right? I thought they'd be counted as gap in care if they leave.
Well, also yeah, that's true, and we don't see that. In fact, gap in care is decreasing. So it could be a situation where you have ultimately better adherence with people being on ART longer. I'm not sure what's going on, but that part is a little bothersome because you don't have any changes in terms of the people on ART. The whole game is out here. You have less.
Does this, sorry for interrupting, I was just wondering where this fell in the dolutegravir approval. Is it possible that
it could be that you have better results with the most recent 5 years. So this is we started 2014, and we're sitting here at 2020. So these people are from 2014. The people from dolutegravir are probably people that are out here. Like 2016, I guess we had dolutegravir, so the last 4 years. So people here. So maybe something's happening here at the 4-year mark with dolutegravir. I think that's totally possible.
Could you just add that to your model at this point?
Dolutegravir
became available.
We did it sort of like with, but that wasn't the. But it turns out that it is the. Sorry. It wasn't the here. It was before and after 2015. As it happens, dolutegravir is around right after 2015 in many cases. Our cutoff at 2015 was because that's where test and treat was introduced. So when we were writing the paper and designing the study, the before and after 2015 was based on the test and treat initiation, introduction. But as it turned out, with the test and treat came dolutegravir. So it's very possible that this incredibly higher level or probability of viral suppression might be, in fact, due to dolutegravir. It also is included, but the other thing I wanted to point out with test and treat versus dolutegravir, if you're trying to disentangle the effect of the two, is here with CD4, and have been several papers where they showed that test and treat actually didn't quite create the advantages that it in survival and everything else, that it was basically by putting people at the low end of the CD4 count more quickly into care. Not so much, and I guess in retrospect that's not very surprising, not so much by putting people that at higher CD4 that would have to wait longer under the triage model, but it was just this change of the culture where everybody gets in instead of having to wait, weeks for adherence counseling and all that. So what we've seen in the test and treat is mainly it's the low end of the spectrum that is contributing the most to the improvement in survival, and not earlier initiation of the high end. Which is weird because these guys would get therapy either way, even in a triage situation, but apparently they wouldn't get it as fast because the culture changed.
And systems, right? I mean, probably they were like, well, we're going to have a lot more people coming for treatment, so we better maybe staff better.
The idea that you show up, boom, you go to the pharmacy and you get your stuff. There's no let's talk about it, and by the time you finish talking about it, you're dead. And this is actually the worrisome part now with the interruptions in care because of because these people are going to be the first ones that are going to be affected.
Is it true that CD4 testing has been less frequently performed since test and treat? And do you think that will come back?
Dramatically.
Yeah. So
and the reason is because the same machines are used for viral load, and viral load is the way that the disease is managed, even though the algorithm says you have to take a CD4 at entry. In our case, we have sites with 17% of those who come in getting CD4. And you cannot tell me this is a random and representative sample of all the patients starting therapy. In fact, we have tried with WHO, while we're still able to speak to them, that to help us lobby to get more CD4 at entry, so we can understand the burden of late disease presentation and things like that. Really important epidemiological indices.
I have one more question. Is our multi-state models, which of our courses are they covered in?
They're not.
They're not.
And it's not too bad because they're very nice R packages that, the hard part is the data management part. To get that data into that context, ask the data manager. Once that's there, you put it in the model, you're good to go.
It kind of sounds like something Jose could do with the same data.
Yeah.
I was thinking the same thing.
Sorry, what was that?
Sounds like something Jose could do with the same data.
Yeah. In fact, it would be great to collaborate maybe. Also, competing risks are not covered in the survival analysis that we do here.
Yeah.
And the reason is that this is a little more advanced piece. That and multiple failures are harder subjects in the survival analysis course.
All right. Well, we're about at the end of our time, so I'm going to thank Constantin and thank Jose. This was a really interesting session today with some kind of interesting method concepts spanning the two. Let me just see. I have to remember who is in our next one coming up. So our next forum is on today's March 5th, April 2nd. We have Marlene Camacho Rivera as our keynote speaker, and Guo Yang as our as our student speaker. Goyi is a student of Mary Schooling, who is here on the call from Hong Kong. So that will be another interesting methodological talk. So thank you everyone for coming, and I hope to see you next time.
Thank you.
Bye everyone.
Thank you.